got 3 speakers today. Just a couple of housekeeping rules. Please mute yourselves if you're not speaking. We've got 3 speakers who are each going to take questions at the end of their section. If you've got a question, please pop it in the chat or just bide your time and raise your hand when it comes to questions. Please don't interrupt the speakers because we are running to a schedule, and so we will make sure that there is opportunity for you to answer questions. Ask questions, sorry, not answer questions. And just to let you know, I don't know who's joined. I don't know how widely spread this invite's gone. There is some focus on Sandwell because that's obviously where we're based. Obviously, there's stuff about grief and bereavement, and the medical examiner stuff is relevant nationally. But we are talking a little bit about provisions within Sandwell. So obviously, if you're outside of Sandwell, it won't necessarily all completely apply to you, but I'm sure there are other services similar in your areas. So with us today, we've got Sue Edwards, who's bereavement lead nurse at Sandwell West Birmingham NHS Trust. Stefania Luzinschi, sorry if I said that wrong, who's Healthy Ageing Development Officer at Sandwell Council. They'll each introduce themselves and their roles as they start as well. And then we've got Kieran Candola, who's Medical Examiner Officer at SWBH as well. They're going to go through, Sue's going to talk about normal bereavement and then complex grief. Stefania's going to focus on support available in Sandwell, and Kieran's going to talk about death certification process and recent changes. If I've said that wrong, then please, I'm sure they'll introduce what they're talking about, but I just wanted to give a brief intro. So I'm going to hand over to Sue for her talk. Can you just confirm, Sue, that the slides have moved along, or Becky, that the slides have moved along? And also just to say, we've got Dr. Becky Dorber here, who's a consultant in palliative care, who's supporting with the chat as well, and has been supporting in this project. So she's on the webinar as well. All right. Over to you, Sue.
Okay. Hi, everyone. My name's Sue Edwards. I'm the bereavement lead nurse for Sandwell and West Birmingham NHS Trust. And we're going to talk a little bit as part of Dying Matters Week, especially that it's about loss, grief and bereavement. Can I have the next slide, please, Carolyn? Thanks. Okay, so first of all, loss. Loss doesn't automatically we think of as it being a death of someone, especially someone close to us, or death of a colleague. But actually, loss is a wider subject. That it can be loss of a job, a breakdown of a relationship or friendship, a loss of home, or somebody being diagnosed with cancer, or and losing breast as part of breast cancer, or a loss of a limb. So loss is a huge area. So then we're going to now focus on grief. So next slide, please, Carolyn. So there's lots of models of coping with bereavement, and the oldest one that I can remember is like Kubler-Ross, and everybody refers to Kubler-Ross and the 5 stages of grief. But things have now moved on a little bit more now, and the dual process model of coping with bereavement was developed in 1999 by Strobe and Schutt. And this model actually it helps us understand a little bit more about with normal bereavement. In the middle of the actual circle is everyday life, and that's the person that's bereaved. And then you've got onto the left loss orientated, where that is all about feelings, emotions, the actual grief feelings itself, that sense of isolation, sadness, anger, that missing that person, and focusing on memories of the life before. And then on the right hand side is restoration orientated, which is how do you figure out how you move forward now, your new role with actually being bereaved, creating maybe new traditions on your own, starting to do new experience and social experiences as well, forming new relationships and adjusting as a different family role. And that will move, you actually oscillate between the two. And it means that maybe that in like the first 4 to 6 weeks, you'll variably be loss orientated, and the focus may heavily be on that. And then maybe in the months following, you may start to feel a bit more restoration. But then there might be anniversaries, birthdays, significant days that you'll actually move back into loss orientated part of grief. But then again, we'll move back into restoration, and that's what it is. It flows between the two. Next slide, please. Tonkin's model of grief is about growing around grief, and we often feel that people think that grief slowly gets smaller and that you'll be okay. That was months ago, that was years ago. You should be feeling now that you can actually move forward and get to acceptance. But that doesn't actually happen in reality. Grief stays the same. It's always the same size, but slowly life begins to change and we grow around it. And that was in 1996, this model with Lewis Tonkin. Next slide, please. The grief brain is how our brain reacts to grief and the emotional trauma that we actually experience when we suffer with a bereavement. It's very much around on sensory. The fight or flight hormones are released, your heart rate increases, blood flow flows more to the emotions and fear-based part of your brains, and the hand model replicates that your prefrontal cortex, which is the area of the brain highly involved in decision making, becomes less active and we develop like a brain fog. So at the same time, your limbic system, which is about survival, takes over. So it's really hard to actually think clearly and make decisions, and that will take quite a while to actually dissipate and for you to actually feel that you're moving forward. Next slide, please. So common reactions to grief. So what we would class as sort of a normal reaction to grief. So the emotional response that you're likely to see is obviously sadness, people feeling sad, anger, fear and guilt. Sometimes relief, especially if they've seen somebody experience a life-limiting disease for a number of years. Numbness, confusion, loneliness and isolation, shock and anxiety, that feeling of helplessness, regret, blame and a longing and pining. So people may come and actually say, well, if only I did this, what if that happened and why did it happen? Especially more so in an unexpected death. Physical responses, people present that they either just want to sleep, to shut out the world, or they don't sleep hardly at all because their mind is so active. They eat more as a comfort, or they eat less because it's just such an effort to actually make a meal. They might struggle with breathing difficulties or chest tightness as part of anxiety feelings, feeling of weakness, and obviously dry mouth in response to that feeling of anxiety as well. With behaviours, that loss of focus and concentration, it's just really difficult to actually think about getting up and focusing on what I'm going to do with the day, because it's just easier to shut yourself away than actually focus on thinking I need to start getting back to some sort of normality. Lack of pride in appearance and self-care, mood swings, so it can be really sort of 1 minute crying, the next minute memorising, laughing, and the next bit really angry and shouting. Forgetfulness, withdrawal from social activities, so withdrawing from seeing friends and family, feel that they're being a burden. People are a burden to the family and friends by keep talking about the loss. Irritability and risk-taking behaviours, so increasing maybe in alcohol consumption, smoking more, eating, changing diet, or even drugs, recreational drugs to help numb the pain as well. Next, please. So hopefully when we say with normal grief, you hopefully would see people start to change and hopefully improve within sort of like six to 8 weeks and then ongoing months. But complicated grief can be when feelings are prolonged over a period of time of greater than 12 months. And that usually affects 1 in 10% of 1 in 10 of the population. And that can be because there's an intense yearning for the person that has died. So the focus becomes completely, the person that's bereaved is on the world of the person that's died, and they can't see any other way forward. The difficulty thinking about the person who has died without strong and negative emotions. So all these different emotions, that's why did they die? Feeling that they've got unanswered questions about that death, and needing maybe that to be answered to help them sort of think clearly and move forward. Experiencing flashbacks to something that may have happened prior to the person dying, and that could be related to any death process, whether that be sudden or expected death. People avoid places or people or things that remind them of the person who's died. But also on the opposite spectrum, they think of them all the time and can't focus on anything else apart from the person that's died. They may think negative thoughts about themselves. That they did not do enough when they were alive to try and prevent their death, or they're not good enough because of that, even though death was inevitable. Not returning to any normal life, including thinking of work, socialising, hobbies, home life, or any responsibilities. Not taking care of themselves, their own health, relationships, not wanting to socialise, or their own well-being. Or feeling that they do not want to live without they can't live without the person that's died, and actually expressing that they want to be with them as well, or having suicidal thoughts or making plans to actually to commit suicide as well. Next slide, please. So how can we support a grieving person? First of all, it's acknowledging their situation. Sometimes people just need that acknowledgement that they've experienced a death, however that death has happened, and an ear just to listen to. They just need to hear that they've spoken to somebody and you're actually acknowledging that they have had a death. Sometimes it's also acknowledging if there's children involved and how they're coping, because sometimes they get forgotten, although they actually absorb a lot more than what we expect. They actually do listen and are aware when a death has happened, but it's making sure that they're okay and checking in with that person, that if they're at school or at college or at university, that they're aware, those organisations are aware of a bereavement, because they can also help support. Grieving may start before the person has died, as we know, with palliative care, in anticipatory grief, so also with dementia. When people are already grieving for the loss of that person, they know that it's going to happen at some point, and they start to grieve for them. As we just said before, letting the person know that you're there to listen. That's one of the best communication skills there is when talking to somebody that's bereaved, because then they'll feel they'll get that acknowledgement and that they're worthy of somebody to be listened to, and that you're not family and you're not going to judge them coming to speak to you about what they're experiencing. Having good communication skills, never making assumptions, because grief is unique to each and every one of us. We'll all experience it differently. We'll all go through it in different ways. Having empathy, because we know that death is inevitable to all of us, but unfortunately it happens at all different ages. Displaying compassion, so people feel that they can open up to you and actually tell you how they're feeling, but also being respectful of people's beliefs and cultures, because everybody has different beliefs and cultures in respect of death and dying. And identifying what support is needed, and be specific is what is available. Does that person feel, if it's isolation and loneliness, would they be more beneficial gaining support within community groups, or do they need something more structured like a telephone or face-to-face support or counselling? And Stefania will go through what's available shortly within Sandwell Borough as part of Compassionate Communities. Next slide, please. Thank you. Is there any questions?
Has anyone got any questions for Sue before we move on? Okay, we'll move on to Stefania. Obviously, if you've got questions that come up as we go, just still put them in the chat. Sue's going to stay throughout, so she can still add on, answer questions later. So I'm going to pass over to Stefania now.
Hello, my name is Stefania Luzinschi, and I work as a Healthy Aging Development Officer for Sandwell Council Public Health. I'm part of the Vulnerable Groups team. If we could next. In terms of data for Sandwell, probably you are already familiar with this, but in 2022 there were over 3,000 deaths.
Sorry, Stefania, are you able to put the volume of your mic up a bit? It's really quiet.
I will try to connect my headphones. It should work better. Can you hear me better now?
Oh, much better. Thank you.
Thank you. So, as I said, you probably know already these things. In 2022, there were over 3,000 deaths, and the majority of these deaths were between 70 to 90 years old. And the highest percentage of deaths in hospital were in hospital, then at home, followed by care homes. In terms of Dying Matters Awareness Week, we are trying to promote planning ahead, open conversations about death and dying, and encourage people to discuss their wishes with their families and eventually include them in a will. We just had staff coffee morning dedicated to Dying Matters Awareness Week, and we had colleagues sharing with us that they had family members who wanted to die at home and they still died in hospital just because family members were afraid they won't get the support they need at home. If we could go to the next slide, please. What kind of bereavement support we've got in Sandwell? We have a variety of bereavement support. We will have very soon a Sandwell bereavement directory developed by Sandwell and West Birmingham Hospital, and we support that directory. I worked with Sue on this, sharing what I've got. We have different information regarding available support on Sandwell Council website, Healthy Sandwell website, Root Wellbeing, ICS, Sandwell and West Birmingham hospitals. However, when I've mentioned Root Wellbeing, what I've noticed, you have to add your services on your own. It's not SCVO adding the bereavement support, and sometimes if you're searching for bereavement support, it might come up as loss matters or grief. It's not necessarily, it doesn't come up straight away if you search by this word bereavement. So this is something that we are trying to work on, to have all the services associated with the word bereavement so that people could find it much easier. We have cruise bereavement services. This is the only bereavement support commissioned by Sandwell Council, and we are aware there might be waiting lists, and probably you want to know what else we've got available in Sandwell. In addition to to Sandwell and West Birmingham Hospital, which you are already aware of. That's why we've created a Sandwell bereavement leaflet, which would be on the next slide. This is a threefold leaflet, and on the back side of this, you will find some local support, national support, and some support lines. We've created this last year, and this year, this month actually, we are trying to update. We've asked all the organizations to provide updates. In terms of local support, we have in West Bromwich KPG, we have in Tipton Murray Hall Community Trust, we have in Smetic Dorothy Parks Community Center, and we also have Sue Ryder. They deliver at Dorothy Parks. In addition to the Lost Matter session delivered by Dorothy Parks, they deliver grief kind spaces. So we have two different bereavement services available at Dorothy Parks. As you can see, we've tried to include, even though when I created this leaflet, I was focusing initially on older adults, we've included Winston's Wish so that we could have a little bit of something for everyone. We've included Blue Cross as a suggestion from one of our colleagues. We are still trying to improve this. If you have any suggestions, happy to take them after when we finish. In terms of support lines, this would remain the same. All of them confirmed they are still operating the same times. Not sure if you are aware of these services, or if you are aware that most of the community organizations delivering face-to-face sessions in Sandwell could provide some sort of bereavement support. Even though they do not have bereavement groups, they will try to provide some sort of support. And sometimes, even if it's just a coffee morning, or an activity, a creative session, they will start discussing about their feelings, and they would be signposted to the existing groups dedicated to bereavement support. If we could go to the next slide, please. To support this bereavement work, we have a Sandwell Health Equity and Compassion Communities thematic group. Sue is part of the group as well. And the aims of this group are care design for our community, with our communities, for our communities, to ensure that there is earlier access to care and support, to improve services and reach out as widely as possible. Last year, we ran an end-of-life care and compassionate communities survey. Maybe we could share with you. I do not have, I didn't prepare the results with me, but maybe we could share these as an email, as an attachment in an email. Also, to help address health inequalities that exist in death and dying across Sandwell, to ensure services and communications are appropriate and accessible in terms of the needs of diverse communities, including culture change within compassionate communities. We recently attended a compassionate communities training, and as part of this, we aim to obtain compassionate communities city charter. But in order to obtain this, we need to tick quite a few boxes. It's a long process, but hopefully we will empower these compassionate conversations, because it's not necessarily always needed a counselor, but a person who is open to have that compassionate conversation. Now that I've mentioned the compassionate conversations, we have created for Dying Matters Awareness Week a timetable of activities. And on Friday, we have a free compassionate conversations workshop. It's really good in terms of empowering conversations about death, dying, bereavement. We had in the past colleagues saying we can't really promote your bereavement leaflet because we are not, we are afraid we might come across people who are bereaved, and what do we tell them? You do not have to tell them anything, you just have to listen to them and signpost them to the right services if you feel you can't do more than this. And I think the Compassionate Conversations workshop would be very good for those who would like to build a little bit more their confidence in having these compassionate conversations. If we could go to the next slide, please. How do we translate these compassionate communities and bereavement support work in Sandwell? Through some practical steps like sharing resources. We have this bereavement leaflet, and we will have soon the directory. We also have the results from our bereavement survey, access appropriate training. Part of ensuring we are able to help others is to help ourselves first. Oxygen, the oxygen mask first. Help yourself and then help the one near you, because most of the times we all support others, but who's supporting us? Our well-being hub colleagues created a bereavement training for Sandwell Council employees, which is really great. Also, we have this compassionate conversations training that could build around the bereavement support work in Sandwell. Probably you are aware about some of the services that I've just mentioned a little bit earlier, like Dorothy Parks, Murray Hall, Age UK, Grief Kind Spaces, KPG. These communities offering dedicated bereavement support. But as I said, there are some other organizations who provide different activities that incorporate elements of bereavement support. And if you ever come across anyone who's bereaved and you would like to signpost them, and you know just about cruise and you do not have the bereavement leaflet on hand, you could try to signpost them to Healthy Sandwell team. Probably you already know about Healthy Sandwell. That's like the call center, the interface of Sandwell Council Public Health. Some of you probably already have an agreement with them and send referrals to them for, I don't know, National Diabetes Prevention Program, weight management, stop smoking support, or other services. However, when you send such referrals to them, if someone says, oh, I've lost, or mentions that they are feeling sad because they've lost someone, or they are feeling lonely, they they will try, they have like a directory of services, and they will try to signpost that person for some activities. If they want yoga classes, they will try to find out if there are any free yoga classes near them. If they do not know about such services, they will try to search and return a call to that person as soon as they find out the information that they wanted. So when we say healthy Sandwell, we say making every contact count. This is their approach. They are trying to explore all the additional needs in addition to the ones for which you signposted them to healthy Sandwell. We've just mentioned the staff, community workers and volunteers to have access to well-being services. We are fortunate at Sandwell Council to have such services, such support. And also during events like Dying Matters Awareness Week, we try to promote as much as possible existing support, available support, and we are trying to build new connections and expand on those. Sue Ryder delivers grief kind spaces just in Smetic, but we are looking to expand to some other towns of Sandwell based on the volunteering offers that we've got. If we could go to the next slide, please. This is the Dying Matters Awareness Week poster I was mentioning a little bit earlier. It includes tomorrow a free will writing workshop. There's also a memory walk on Thursday, 8th of May. An open... Sorry. Did you book this room? Sorry, I think I'm just being kicked out. There's also a memory walk on Thursday of the 8th of May, where we will try to empower open conversations about death and dying, discuss about available bereavement support in Sandwell. Okay. You have here the memory walk poster. In case you want more details, I'm happy to provide after. If we could go to the next slide, please. So as a summary, as you mentioned a little bit earlier, bereavement is a journey that and every person's experience is very different. However, we can work together to provide support via our staff, volunteering opportunities, signposting to services, and obviously working in partnership with local communities and exploring the support they provide. Focus on concepts of compassionate communities which promote an inclusive approach to approach working at community level for all ages. And as you already mentioned this thing, there is no wrong or right way, but people will appreciate someone checking in and providing support that is best for them. As I've mentioned, we had a staff coffee morning a little bit earlier, and one of our colleagues was a little bit upset that when she returned to work after her husband passed away, no one said anything to her, nothing, no word. Probably they were afraid of saying the wrong thing, but not saying anything made it even worse. She felt like no one cared because no one said not even a word to her. It felt like nothing happened. So things like this, they are small things, but are so important. It's so important to ask, are you okay? Are you really okay? Sorry, is my time up? I had the feeling. Am I okay with the time?
Sorry, yeah, you can finish your slides. I can see you've only got a slide left. You should be okay.
Oh, okay.
Yep.
Okay, thank you. This being said, please don't forget to reflect and think about your feelings, experiences too, when supporting others. Obviously, if someone mentions, I do not want to be asked anything, I do not want anyone to say anything, the best practice is to respect their wishes, but otherwise try to show a little bit of empathy, compassion to your colleagues or to those who you are supporting. Next slide, please. Now, final thoughts. If you, this is the Tree of Life. This is something that we've created last year with Sue for Dying Matters Awareness Week. It's our Tree of Life, and we are very proud of it. It has on its leaves some messages for those who lost their loved ones, or some messages for friends, or some just general messages that they wanted, positive messages. So if you would like to take a few seconds to write in the chat box a positive affirmation or a message or a quote for our Sandwell Tree of Life, I will make sure I will copy that message and add onto a leaf. Next slide, please. Thank you so much for your attention today, and happy to answer any questions.
So just a quick pause. If anyone wanted to ask Stefania anything, then feel free to do that now. And then we'll move on to Kieran. I'm just going to, I seem to have opened the wrong PowerPoint that hasn't added Kieran's slide into it. So I just need to quickly stop sharing and open the new one. So sorry, give me 2 seconds.
May I just add that this year's theme for Dying Matters Awareness Week is the culture of dying matters. And just as a fact, what we've discussed, we were discussing a little bit earlier regarding mourning colors. We were trying to share experiences from different cultures so that we could understand better our neighbors, our service users. For example, in some cultures, or in most cultures, black would be the mourning color. However, in some other cultures, it would be white. For example, Hinduism, in some parts of China, where white is used to represent purity, spiritual rebirth. In some others, like Thailand, it's purple. In South Africa, for example, it's red. In Egypt or some parts of Mexico, it's yellow. So small things like this could help us understand those around us. Thank you.
Thank you so much for that. So I'm just going to hand over to Kieran, who's works for is a medical examiner's officer, and she's just going to talk through her slides now. Thank you, Kieran.
Hi, so just a few slides from me about the medical examiner service and the changes that have come into place since September 2024. So the medical examiners team, they are trained senior doctors from a range of different specialties, and we've also got some GPs who provide independent scrutiny of deaths that are not taken at the outset for coroner's investigation. So we're reviewing all deaths that don't need to go to a coroner. All medical examiners in each trust, they're supported by a team of medical examiner officers. So at Sandwell and West Birmingham, we've had an ME team in general since April 2018, and currently the team's got 21 medical examiners in total. That includes 5 GPs and 16 consultants, and they're supported by 4 medical examiners officers. So the aims of the medical examiner role are to provide a better service for the bereaved, an opportunity for them to raise concerns to a doctor who's not involved in the care, and just ask any questions, any clinical questions that they may have about the care that their loved one received, something that they weren't able to get answers to during the time that their loved one was in the trust, or during their time in the community as well. Also to improve the quality of the death certification, so the MCCD that the doctors complete, and also to improve the quality of mortality data. We report to NHSI on a quarterly basis, and we're also funded externally as well. In order to achieve these aims, medical examiners agree the proposed cause of death and the overall accuracy of the medical certificate with the doctor who will be completing it. So whether that's GP, if the patient died in the community, and or a doctor in the trust if they died at any of the hospitals in the trust. They will discuss the cause of death with the next of kin also and establish if they have any questions or concerns with the care, or just if they, sometimes next of kin just want the cause of death explained to them just a little bit better. Sometimes there's medical terminology that they won't understand, and a clinician can break it down easily and just explain what caused the death and what the conditions were leading up to that. They will act as a source of medical advice for the local coroner. So even though we don't need to review coronial deaths, sometimes there will be a bit of a crossover where a death's come to us, but then the medical examiner thinks it needs to be referred to a coroner, or vice versa. So we do keep in contact quite a lot with local coroners, and the medical examiners act as a resource for them, and inform the selection of cases for further review under local mortality arrangements and contribute to other clinical governance procedures. So once a medical examiner has reviewed a death and or spoken to the next of kin, if there's seen that there's any problems in the care, we'll either provide direct feedback to the ward or the GP, or if it's a little bit more serious, they'll raise a structured judgment review and it will get reviewed by a mortality lead. And I think there's going to be a process for the then equivalent to an SJR in the community, but that's being worked on at the moment by the ICB. So since September 2024, independent scrutiny by medical examiners became a statutory requirement. And so all non-coronial deaths have to be reviewed by a medical examiner before they can be registered. No registrar will accept a medical certificate if it's not being countersigned by a medical examiner. So this is our process at the moment with community deaths. And at the moment, the patient will pass away in the community. If it needs to go to a coroner, it goes straight to a coroner. There's no referral required for an ME. If there was no GP who treated the patient in the lifetime, or they're not able to write an MCCD in a reasonable time frame, again, that goes to the coroner. But if it's a natural cause of death, the GP is available to complete an MCCD before they can just complete the MCCD and send it off to a registrar. Now they would need to complete the pro forma, and the admin team will attach a 6-month clinical summary, send it to our medical examiners team, and we will review the death prior to it being registered. The GP will send these via email. The medical examiner will complete the scrutiny, speak to the next of kin, either themselves or an MEO will do it for them. And then our medical examiner officers will email the GPs with the outcome of the scrutiny and a reference number to say that the review has been completed. And the MCCD is already written by the GP, scanned as a PDF and emailed to the ME office. Our medical examiner then countersigns that, and then we send that straight to the registry office, and we will CC the GP practice in so they know that we've sent it. It's been working so far. It's been working well. It's not really caused that many delays. The majority of delays that we've received at the moment are where the referral in general has taken a delay to come to us in the first place. Once we receive the referral, we do get it reviewed within the day or so. And if it's out of hours for rapid release in the trust, we have our process, but there's no rapid release process in the community where the GPs are working out of hours. So I think that's something in the pipe, something that you could think about, but again, each GP surgery will have their own process for that and their own thoughts on it. But we've got a process in the trust, and if it's a rapid release, we have out of hours MEs who work on the weekends 9 till 12, and they'll get any urgent scrutinies done. So since September, these are some points that we've noticed with community deaths that we're kind of struggling with, and there's a bit of back and forth, and it's causing a delay for the MCCD to be completed. So the place of death on the MCCD, we've noticed some GPs of putting home. We need the address on the MCCD because again, that's causing back and forth. We're having to go back to GPs just to redo that. Again, there's no reason to refer to a coroner simply because their patient hasn't been seen in the last 28 days. It used to be 14 days, then during COVID it turned to 28 days. Now it's seen in life. So if you have seen the patient it doesn't have to be in the last 28 days, and so that doesn't need to go to a coroner just because you've not seen them recently. You'll just need to have seen them in their lifetime. All sections on the MCCD need to be completed. There's a new section about pregnancy. Even if it's a male, that needs to be completed, and it just needs to say not pregnant. It needs to be circled either way. There's a lot of MCCDs that we're noticing because it's a male. I think GPs are thinking we don't need to circle that, but we still need to complete it. Again, with ethnicity, something needs to be circled in the box, and if it's unknown, there is an option to just circle unknown. So it's just completeness of the MCCD really, because we're having to go back and ask for that. It's causing a delay for families, and they're contacting us asking what's happening with it. There is a list of hazardous devices, again, which are included on there, and I can share that if anyone wants to see it, as a refresh. And also there's just in general sometimes been a delay in referring to us in the first place, so we're not receiving the referral of someone who's died in the community. Sometimes it's been a week, and so by the time we review that, it will be over a week, and it's just causing a delay for the family if they wanted to register the death. So really, as soon as the GP surgery know that there is a death in the community, it should be coming to us straight away really. Other than that, it is working well so far, and that's pretty much everything from me. But if you have any questions, please let me know.
Can I just ask, I think there's a question in the chat we'll come to in a second, but can I just ask you, in your process you said a reasonable time frame, so if the GP can't complete it in a reasonable time frame, obviously sometimes the GP might be on leave for 2 weeks at a time and they die at the beginning of the leave. What's your definition of a reasonable time frame?
There is no actual definition, but we're saying, like, for example, if someone's on leave for 2 weeks, that should warrant a coroner's referral, because we try and get in the hospital deaths, we try and get them turned around within 3 days.
Yeah.
So if around that time frame isn't really possible, and you know that the GP is going to be on leave and no one else can do it, or no, the GP hasn't seen them in their life, then that's fine for a referral. Obviously, if it's like a day or two, then we'd expect for them to just wait, unless it's for religious reasons.
There's a question which, Sue, you might want to weigh in on as well in terms of religious reasons. So the question is around rapid release. It says, what are your timeframes for patients who need a quick turnaround due to religious reasons? I think you did touch on that, Kieran, but obviously it's slightly different in the community as well.
Yeah, so from our perspective as an ME team, we'll aim to get rapid release ones done next day, as soon as we know it's a rapid release, or if it comes through in the morning, we get it done the same day. That's the only thing that we can speak for is the medical examiner's review on it though. So for example, on a weekend we have a medical examiner out of hours on Saturday and a Sunday from 9 to 12, and we kind of get it to tie in with the registry office hours. But then, for example, if that patient is, again, if it's a community death, the ME is available, but there's no admin staff in the community or the GP who will send us the referral in the first place, so that the delay there isn't really from the ME service side. For hospital deaths, we try and get it done either the same day or the next day.
Did you want to comment on the community element, Sue?
Yes, same as what Kieran said. For hospital, obviously, it's an easier process because patients with us, and we've got the system in place to review. Regionally, I don't know of any other GP surgery at the moment that are actually doing a rapid sort of release process, unless that death certificate has been completed and sent across to the ME for review, and that's what can happen. The ME is there, as Kieran just said, weekends and bank holidays, and as soon as that ME receives the death certificate, they'll have the contact from the GP or from the hospital doctor. They'll scrutinise the notes and then guide on what to put as cause of death, and then that can be completed and sent to registry. So yes, we can do it quite quickly in the hospital, and it's equally the same as if we were to receive one from a community source as well. It's just logistics of who's seeing that patient and getting that scanned and across to the ME for review.
I think practically in general practice, if it's a weekday death and there's a GP there available, they can turn it around that same day. The issues arise at weekends when GPs aren't available to do it.
Yeah.
And there's another question. I don't quite know what you mean by this, Royce. I don't know if you want to unmute and mention. Does the ME team follow the GP place of death hospital?
Okay. Hi there. GP, I'm actually from a Dudley practice. We have our own ME service, Dudley ME service. We're in a situation where we border quite a few boroughs, so we border onto Sandwell. So therefore, if a patient passes away in a Sandwell place, do we discuss with the your ME team, or do we discuss with our ME team? Likewise, if they pass away at Sandwell Hospital, then is that discussed there or with your team, or do we go back to our team to have a discussion?
If it's a patient who dies at Sandwell Hospital, they will come to us either way, because they've died in our trust. I think it depends on, if they're living in Sandwell, it would come to us. But
Okay.
I think if you'll find that if it's a GP, it's not actually where it lives, sorry, ignore that. So I think it's if the GP is based so you're based in Dudley.
Yeah,
aren't you?
correct.
So then it would go to Dudley.
Regardless of where the patient passed away.
I guess
Okay.
if they died in Sandwell Hospital, then
Yeah.
the GP won't be
Yeah.
dealing with the death
So it's
certificate. It'll be a doctor in
place
the
of death,
hospital, and that would go to Sandwell ME. Whereas if they die in the community, it's based on GP, isn't it? So
Yeah.
if they die in the community care home or home, then it's you as the GP. Then it goes via Dudley ME. If they die in Sandwell Hospital, it does go to Sandwell ME, but obviously that doesn't involve the GP because the doctor in the hospital is doing the certificate.
Okay.
If that makes sense. Yeah.
No, that makes sense. The other thing was just to clarify, just see whether it marries up with our service. So if our patient goes in and they dies en route in the ambulance, they're technically in hospital. Our local ME service would still forward it back to us because technically they were not seen alive at the hospital. Is that still the same process with your team?
Yes.
Yes, it is.
Sorry,
Yeah.
it is. Yeah.
Yeah, perfect.
Yeah. Any other questions for anyone? I just wondered if I could put a question to Sue before we finish about, obviously you touched on complex grief and what it is. Are there any differences in how, and you talked about how to support people going through grief, obviously being open and listening, etc. Is there anything you offer or do differently when, or how should we respond to somebody that we see with complex grief in terms of onward referral? Is there any services? Obviously, we've talked about the services which are available for normal grief, but the question is there something different if it's complex grief, or is it just, that continuing process?
Yeah, there is. So sometimes, say if a patient's died in hospital, and the family are struggling, and it's due to what's happened within that episode of care, and it might be that they are just stuck and needing further information, then sometimes we'll sit with a consultant who's been responsible for that care and just unpick that episode of care with that family and ensure that they fully understood that reason for death. Because sometimes if there's an unanswered question or a piece of jigsaw not fitting right, then that's what we'll need to explain, and that sometimes is enough to help. As in other complex grief, as in sort of like bereaved by suicide, sort of unexpected deaths within hospital, as in like an A&E death, such as a cardiac arrest, a road traffic accident. Sometimes with that complicated grief, families will need possibly sort of support by counselling. Stefania explained about CRUISE. CRUISE is the national, one of the national sort of advocates for counselling, but locally we have got Sandwell and Walsall. Dudley have also got access to CRUISE as well, and that's telephone counselling. They don't do face-to-face counselling, unfortunately, that's since COVID, but they will offer usually 6 follow-up phone calls. However, the waiting can be about 6 to 8 weeks, and that does vary. Sometimes it can be more than that, but they will go through obviously doing telephone consultation and counselling support. Face-to-face bereavement support, the only ones that I know that is free within Sandwell for people to access is Beyond Blue. They're based in West Bromwich and Wednesbury, and they will do not just bereavement counselling, but counselling support for all different mental health and emotional problems for all different ages, children to adults. And that's also, you can get that you can find that on via Google, via Sandwell websites, and also on Route to Wellbeing as well. So they do free Stefania mentioned about Kaleidoscope as well, KPG in West Brom. They have sanctuary, they have bereavement groups. So where somebody might want to go and attend a group, some people even with complex grief might want to go and actually be with other people that have experienced a bereavement, because they truly understand what it feels like to go through a type of loss that they're experiencing. So there's different groups there at West Brom in Kaleidoscope, Dorothy Parks, which are based in Smethwick. We've got Murray Hall based in Tipton. They all do face-to-face groups, but that is more like befriending and talking through, and people like having, coffee mornings and just chatting together through that grief. I'm trying to think what else there is, but there is also bereaved by suicide. That's a specific type of a specialist type of bereavement support because of the nature of it. Often the complexities of suicide, of somebody committing suicide and that family, or informant not knowing that was even an intention, or sometimes not even being left having an insight that was going to happen. That we've got actual bereaved by suicide group. They'll do telephone support, website, and they've actually got a group support as well. And they're also on the actual leaflet that Stefania spoke about, and that's bereaved by suicide, and that's for Dudley and Sandwell as well, for the whole Black Country network that families can access as well. So if you just put bereaved by suicide Black Country, you'll be able to get all the contact details for referring there as well. The directory that Stefania said has just come out in print, and so that is available for circulation now with Stefania's leaflet out to GP areas. If you feel that's a benefit, let us know. We can get that out to you, where you can actually put that into receptions where people can just take it away, and that might be enough for them to sort of self-direct themselves into what sort of support they need, because it's knowing what they want, because nobody's sure of what they need. So it's telling people what's available and signposting into those services is enough often for people to feel listened to and actually self-navigate themselves around. There's a lot of community support and a lot of faith support as well, that people sometimes feel that that's what they need, or support within their own sort of social circle. So it's asking what they want. Sometimes it's just asking, what do you think you need? What's going to be of help? And then signposting into those services. I don't know if that helps, Caroline.
Yeah, no, that's really good. Some additional information that's key. And we've actually within YHP, we've added your leaflet to our death process. So when the secretaries communicate out that they've sent the MCCT to the medical examiner, we've got a link in our AccuRx. I don't know how many people use AccuRx, but just send that as a link. Say, we're sorry for your loss. Here's some sort of services available. So that's something that people could consider. Even just
you can have the QR code as well to the bereavement directory. If that's any help, let us know. We could get that as that's being just done as a QR code at the moment, and that can you can utilise that alongside the leaflet if you feel that's any help. It's just got some more sort of information in about looking after yourself and how to talk to children, etc. Some sort of tips for people to, when they read, to help with those sort of discussions as well.
Great. Well, I think that brings us to the end of our planned stuff. Becky is just going to share. Do you want to just quickly mention it, Becky, what you're sharing for everyone?
So within Sandwell Hospital, we've just developed a Teams channel for palliative care that we're hoping to share the link with, so that as many people as possible in the community can join. So what's on there? It's basically guidelines and any new events that we're putting on, educational events, links to the West Midlands guidelines on there, and all the resources that we have available for the hospital staff. So what's on our hospital intranet is going to be available on there as well. So there's like videos, teaching aids, loads of stuff. It's brand new, so you're getting a bit of a sneak peek. So I'm just going to put the instructions of how to access it into the chat. So if you click on the home button, it should bring up the Teams channel. And then in the top right hand corner, there is a star where it says follow next to it. So if you follow, you should get then updates that come through when we add new things to the channel. and you can see if they're relevant for you. So hopefully that will work. I did try it out and it worked earlier. So yeah, and share it widely with your colleagues. And we want as many people to be able to access that as possible. Okay.
Oh,
You're
unmuted. Yeah, just realised. Yeah, I was just saying it includes links to the oh, it says access denied. I wonder why. You do. When I tried to click on it myself, you do have to log in to NHS, your NHS emails. We'll find a way to share it if this doesn't work anyway, because we're going to send it out to people that have joined meetings and things. So we're in.
Okay, thank you. It's we'll send it out separately anyway. I was just going to share it a bit early if I was able to, but we'll have to have a look at why it's not letting you.
Thank you. It was worth the try, but we'll share it out via a different
We'll share it
via the
properly.
same route that we shared this meeting. So you should be able to access it once we've sorted it. But it will include guidelines, like link to the West Midlands guidelines. We share these webinars because we've done actually a whole
series of
webinars which are all recorded and can be shared. And yeah, all right. Well, thank you for your time. I'm going to stop recording. Any last questions before we go? Otherwise, have a great day, everyone. And thanks to our speakers.
Thank you.